Good afternoon, and welcome to this month's Northern Virginia Health Policy Forum. I'm Jim Scott, President and CEO of Applied Policy, a health policy and reimbursement consulting firm based in Alexandria, Virginia. As 2026 gets underway, federal discussions on Medicaid policy continue to evolve, with several proposals under consideration that could have meaningful implications for providers, beneficiaries, and state health systems. Today, we welcome Verlon Johnson of Essentra Health and current chair of the Medicaid and CHIP Payment and Access Commission, otherwise known as MACPAC, and Cheryl Powell, our own Medicaid expert, Vice President of Health Policy here at Applied Policy. Welcome, and we're excited to hear from you today. Let's get started off with a couple of introductions. So I didn't do a very good job. So Verlon, could you go introduce yourself and tell everybody a little bit about your background and what led you to where you are today?
Yeah, absolutely. And my mom would say you did a great job. So thank you. Thank you, Jim. But just expand a little bit more. So, right, I am at Accenture Health. We are a company that provides health IT and solutions for state and federal partners. And I do serve as the government and corporate affairs chief here. Been here for about 5 years. But actually, before coming into private industry, I spent nearly 25 years at the Centers for Medicare and Medicaid Services. Many of you know it as CMS. And I actually got there deciding that I wanted to work in healthcare, but also realizing pretty quickly that becoming a clinician wasn't in my cards. I couldn't be a doctor because blood, y'all, was a hard stop for me once I understood that doctors really had to deal with that every day. But if you look at my background, I think one thing you really notice is that Medicaid really has been that through line throughout my career, even though I didn't start there. Earlier on at CMS, I actually worked on Medicare, specifically Medicare Part D, including the low-income subsidy. And at that time, that work really closely coordinated with state Medicaid agencies. And that fundamentally changed how I really understood healthcare policy. But I knew why I wanted to move into Medicaid because I had seen what Medicaid does when it works well. And it's not just policy, it's really, to me, more about possibility. And it's really that difference between uncertainty and stability, between really surviving and truly thriving, I think, as humans. And so that decision to change over really changed the course of my career. And it honestly has really shaped who I am. So when you hear me say throughout this time today that Medicaid matters, it's not theoretical at all. It's really very, very much personal for me. It's really about the families that I've met. It's about, the programs that I've supported and the leaders that I've worked alongside who understand that Medicaid is not just a side program. In our healthcare system, it really is a foundation of access and equity in much of America. So that's me in a nutshell and why I love Medicaid so much.
Great. Well,
Thanks, Verlon.
I'll dive in and introduce myself and say Verlon's love of Medicare and then Medicaid is infectious. She is the reason that I ended up focusing much of my career on Medicaid as well as Medicare. I was fortunate enough at CMS and then throughout my career to work on private health insurance, Medicare, and Medicaid, which I've continued throughout my career. Here, I am now at Applied Policy, the Vice President of Health Policy for Health Services, where I am fortunate enough to help systems and providers and health beneficiaries really improve lives and doing that through a health policy expertise. So I first engaged in Medicaid with Verlon in the Chicago regional office with the Medicare drug benefit as that was coming into being. And again, it was that ability to work with the Medicaid programs and the state pharmacy assistance programs as the drug benefit came into being that really ignited my love for Medicaid. I bit the hook at that point, and then I was fortunate enough to move from that into being a deputy director of the CMS 1115 area in Medicaid, eventually director of benefits eligibility and managed care, a technical director for Medicaid financing. And then all of that deepened my love for working with this amazing program that serves so many people is flexible enough to meet the needs of the state's beneficiaries and providers across the country and serves really as our safety net here in the United States and works with all other forms of coverage and the provision of care. So with that, I was able to move on to become the inaugural deputy director of the ACA created Duals office within CMS, where I got to continue working with Verlon on issues related to the dual eligibles, Medicare and Medicaid, both in the innovation area and also within program alignment, trying to make sure both programs that were created separately could work better together to best serve the needs of individuals who have both Medicare and Medicaid for their coverage. And then I eventually left CMS. I spent 16 years there, but throughout my career have stayed very close to these programs. I'm passionate about them and here to help optimize outcomes across systems for beneficiaries with states and all of the stakeholders within the healthcare system.
Well, thanks, Cheryl and Verlon, and our audience, I'm sure, can see why we're grateful to have Cheryl on our team. So, Verlon, let's turn back to you. Congratulations on your role as MACPAC chair. Can you tell everybody a little bit who might not be familiar with what MACPAC is and why its work is important, and then go on to say what your priorities are for the coming year?
Yeah, absolutely. So, just to back up a little bit, so my perspective and love of Medicaid actually is what led me to MACPAC, which is the Medicaid and CHIP Payment and Access Commission. And just so for those of you who aren't aware, MACPAC is a nonpartisan legislative branch agency that provides Congress, the Secretary of HHS, states with policy and data analysis and recommendations for the Medicaid and the Children's Health Insurance Program. And so our role in MACPAC is really to bring evidence, context, and operational insight to really complex Medicaid questions, right? And so anyone out there who knows Medicaid will say, "Oh, is Medicaid complex?" Yes, we all know. We all know that it really is. But it's really grounded in how the program actually works across states and communities. And I've had the honor and the privilege to serve as commissioner for 5 years, and I've actually served as chair since 2024. And I do just want to step back and just to be clear that the views that I'm sharing here today are my own and do not necessarily reflect the views of MACPAC. But I'm always happy to talk about the great organization, though, and what it does. And one thing I always like to remind people is that MACPAC, there's that P in MACPAC is for payments, right? And so when the commission was actually created, it was charged with examining the intersection of payment and policy. And as a result, payment and reimbursement issues are always a core focus of our biannual reports because how Medicaid pays directly affects access, quality, of course, and system stability. And so that lens you'll see if you study anything we're doing goes through all of our work, where we're looking at eligibility enrollment, managed care oversight, access for people with complex needs, or long-term services and supports. We're always asking those policy questions, how do they interact with payment structures and what that means in practice for states, providers, and beneficiaries. And so across our agenda, there's always a strong emphasis on data, systems, and accountability, and really making sure that decisions are informed by evidence, of course, and reflect real world experience and not just theory is important. And so all this work is very public. In fact, we have a MACPAC meeting this Thursday and Friday, and I'd encourage anyone on this call who's interested in Medicaid policy, which I hope you all are because it's such a wonderful program, to follow along. And so our meetings and our reports and our analysis are available at macpac.gov. So hopefully that's helpful to put that in perspective.
That's fantastic. I'm going to chime in and just emphasize, first of all, I'm the ultimate MACPAC fan. I don't know, I might have to start my own fan club for it. I highly recommend tuning in. They're always so educational, inspirational. I recommend accessing the amazing array of resources that MACPAC has made available and also following the meetings, reports, et cetera, to see those issues that are emerging and the innovative solutions that are explored. And also, it is a fantastic way to participate and to have your voice heard through MACPAC that will directly inform those recommendations that MACPAC puts forward. So I just need to put a plug in there.
Yeah, thanks for that, Cheryl. Very important because your voices are very important. So we do need to hear those for sure. Thanks for that.
So, Cheryl, everywhere we turn this year, the conversation is about Medicaid. Can you help us understand the program a little bit better to level set before we get into the details?
Sure. And I'll start off. I'll set the stage a little bit. I'm sure Verlon will add throughout as well. So I'll just start with Medicaid is a program that's administered through a state and federal partnership, which is a key aspect and theme that runs throughout all of how Medicaid is implemented. It covers about 71 million Americans at this point, or 20% of the population. States within that federal and state partnership have a lot of flexibility. They design and implement the programs under federal guidelines and requirements. So there's a tremendous amount of flexibility in design of benefits, payment methodologies, delivery of care, and even eligibility can be different across states because of the flexibility. The federal and state payment design allows states to draw down federal funds. So it is shared across state and federal governments down to the payment, how expenditures are covered. And that is why financing is often in payment, as Verlon was saying, is often front and center in the Medicaid program and in that relationship between the states and the federal governments or the federal government. So they're allowed to draw down the funds when there is a expenditure made, and they can pull down federal financial participation when that expenditure is made under an approved Medicaid state plan or waiver program, and that it is made for a covered benefit for an eligible individual that is receiving care from an eligible provider. So those are sort of the requirements around when an expenditure is considered a Medicaid expenditure. The total cost nationally is just over about $900 billion, and that's split between the federal and state government on nationally a 65% federal, 35% state basis proportion. But when you look at specific states, that proportion varies across states based on a formula set in statute and applied to states. So Medicaid is truly, as I mentioned before, the payer of last resort. It is a crucial part of our national safety net, and it supports rather than supplants the other payers. So it works closely and supports Medicare, private insurance, and works closely with and is a vital partner to entities such as the FQHCs, school-based clinics, and other community health clinics. Now, who is served by Medicaid? Just about for the 71 million that we talked about at this point, just under half of those individuals are children. And it's important to note that Medicaid is the largest payer for a variety of different types of coverage. It covers about 40% of the nation's births under Medicaid, and that can range up to 60% and to over 60% actually in some states. It serves a diverse and large population of both adults and children with disabilities, and it's the primary payer for long-term care. So it is the primary payer for 63% of nursing facility residents, and it by far covers the most home and community-based care in our country so that individuals with disabilities and who are aged can live and thrive independently where they choose in their communities and in their homes. And with that, I'll turn it to Verlon to share more, but I just wanted to set the stage. It is such an important program that covers so many Americans who really need the coverage.
No, that was great. I agree. So, Cheryl really laid out what Medicaid is and who it serves, and, really giving you that understanding of how massive and how important it is. And I just kind of want to build on that with really how maybe policymakers tend to think about it. If I had to describe Medicaid in one word, it would probably be infrastructure. All right. It's not just a coverage program. I just want to stress that, right? It's what really stabilizes health systems during economic downturns, through public health emergencies, which I know we all here lived through one for sure, and demographic shifts for sure. And because it's jointly funded, as Cheryl pointed out, and administered, Medicaid is actually both a policy tool and a budgetary pressure point. And so if you look at it from a state perspective, at the state level, Medicaid is a major state budget line item. It's usually I think it's usually the state's biggest expense after K-12 education. So that just really tells you the importance it's put on and the mass of individuals that it could serve. And so that dual role is exactly why Medicaid sits at the center of so many states and federal debates as well, because it's an important program. A lot of people are covered on it, and it really is a huge budget item for all of us, for sure.
Thanks, Verlon. And then this past July, a new bill was signed into law that had some Medicaid changes. Can you tell us a little bit about what that bill was and what are some of the key changes that it made to Medicaid?
Yeah, and let me talk a little bit first about what's changing fast for states. Even before we get to the more specifics about the bill. And I think, what we're really watching most closely right now is how states are responding to, some of these pressures, fiscal constraints, workforce shortages. They've got, maybe some obviously heightened federal expectations while still trying to modernize and meet the needs of their constituents. And so, this is the moment where modernization stops being aspirational, as you hear, and becomes more operational for states. I think, if you look at what's happening in 2026, and we'll talk more specifically about this too as well, states are really really trying to figure out how to use data a lot better through their interoperable systems, really trying to think about technology and make it more scalable to make things like eligibility, enrollment, and oversight decisions faster and more precise. And I think also what's noticeable is really how the variation across states is widening, right? Not just in policy choices, but really in administrative capacity too. And so this is really where it really matters where the federal expectations increase. And so when you think about this bill or the passage of OB3, I think we've heard it called. I think it's now called, right, Cheryl, is it called Working Families Tax Cuts Act? I think that's the new term for it. It rarely represents one of the most probably consequential federal Medicaid shifts in recent years, not just because of the scale of the changes, but really because of how they land at the state level. There's a Congressional Budget Office, or CBO. Most of us follow them very, very well, but if you haven't, it's a very a great office that really helps to estimate a lot of the different funding and spending. But they estimated that it will reduce federal spending roughly by, I think, over $1 trillion spending over 10 years. And it's going to be phased in with things like eligibility changes, redeterminations. You've probably heard a lot about work and community engagement requirements. Things like cost sharing are be part of that, and some financing mechanisms. And so from a state perspective, I think the challenge isn't any single provision for them. It's really this overall operational impact with all these different changes that are happening. So I don't know, Cheryl, anything else you want to add about that piece of it? I know from your lens.
I'm going to highlight something that you talked about before
Yeah.
and tie it into this piece, and that is um, I've just been in awe of Medicaid programs' ability to rise to the challenge. And as you mentioned with the pandemic, there were approximately 20 million people added into the Medicaid rolls in a very short period of time within the pandemic. And it was another period of challenge, which created opportunities and into which Medicaid and their partners with health systems, providers, IT vendors, all, flexibilities which allow people to receive care maybe in alternate settings. It really met the needs of the population and allowed so many more people to be covered through the pandemic and then unwind gracefully afterwards as some of the coverage protection or coverage continuation requirements fell away. I think we're going to see sort of that not the scope maybe, but the same types of challenges and the same types of innovation with people rising to that, rising to new opportunities to use IT, as you were talking about, to enable better care and care process, delivery processes, engagement with beneficiaries and engagement across partners to ensure that these new provisions coming together as they hit in a relatively short period of time are met with grace and met with innovation, given, again, the limited resources of time and funding to support them. So I think you're right on when you say it's really the challenge of how these things are hitting them together. And then the goal of implementing and making the most of those the implementation from those challenges. And what I love about Medicaid that I see over and over again is that challenges are not only met with enthusiasm, excitement, and expertise, but always the end result moves us to a better place. We end up, yeah, we evolve, we truly move forward. And it is a group of people, stakeholders all coming together that are constantly asking, how can we make this better and moving towards that better? And I think that's what this challenge, I know that's what we're leading towards with this challenge as well.
Yeah, I agree. I agree with that one for sure.
Thanks, Cheryl. So one of the key provisions of the bill that people are talking about is the Rural Health Transformation Program. Whichever, I don't know who wants to go first, but we'll ask both of you. So let me start with Verlon. What is the Rural Health Transformation Program and why are people excited about it?
Yeah, I was actually going to let Cheryl go because she excites me even more to talk about it. So, Cheryl, do you want to jump in first?
Yeah, so with the Rural Health Transformation Program is near and dear to my heart. Most of my family receives care in rural areas, in southern Missouri and throughout the country. And the Rural Health Transformation Program is infusing states to work with their partners to bring higher quality care, to bring resources to rural areas to help people, again, thrive in their communities in areas that have been supported through programs such as critical access hospitals and other innovative programs that Medicaid agencies have put in place, other stakeholders have worked on. But this is really, funding that is directed at supporting whole-scale transformation and in bringing together stakeholders from across the states to focus on critical issues in rural areas to really improve care and access. Access is always an issue for rural areas and to bring the expertise, the specialists, the best of the best to those rural areas. And so it's, I think, an opportunity for healthcare systems and providers to really engage with state leaders and with the voices of rural beneficiaries to make sure that care is provided in a way that meets the needs of those communities and supports long-term sustained change, some being technology enabled, others being very focused on the culture and the needs of the community. So that's why I'm very excited about this program. I'll hand it to you, Verlon, if you want to highlight other aspects.
Yeah, I mean, and that's it. Like if you're whatever state you're sitting in and listening to this, if you have an opportunity to understand a little bit more about how your state is thinking about this, it is such a fascinating opportunity to listen, right? Because this investment, what $50 billion really gives states more real flexibility and really rethinking how care is delivered in rural communities. And so for states, this isn't really just about keeping doors open, right? It's about stabilizing rural hospitals. It's about strengthening, primary and behavioral healthcare access. It's really about supporting the workforce models that actually work in rural settings. Because let's be honest, doesn't one model that works in inner city does not necessarily work in rural settings, right? And it's also about using technology to really connect patients to care that they otherwise wouldn't have an ability to do. So as Cheryl said, CMS has already awarded their awards to the states. Every state has funding. They're going to begin to draw that down over the next 5 years. And what matters most in this is how deliberately states use that flexibility and whether those investments translate into sustainable access and not just short-term relief. We want to see this just, continue to be a positive thing for sure. But definitely, I applaud the administration and CMS for really pulling this together because it really is going to give some great relief to the states as they need it.
Thanks, Verlon. Cheryl, how So every state already got its money, so it's ready to spend the money. Did they all get the same amount of money, or was it based on a formula, or did they have to apply for their share of the 50 billion? How did that work?
There was an application process through which states were able to apply for a grant. There were multiple different buckets where they focused on. CMS looked at all of the grants and awarded based on what the state had proposed in their application. And the grant awards have been made. It doesn't mean that they necessarily have all the money sitting in their bank account right now, but the awards have been made. States know what the funding amounts are, and they have been awarded based on what was in their application. The exciting thing is that each state applied, each state received funding, and then they will receive additional funding based on their implementation of the grant program that they outlined in their application. Most states really worked well, pulling in a very short period of time, pulling in stakeholders from around the state to help them design and drive what those programs would look like. And therefore, each one is a little unique. There is a strong aspect of technology, interoperability, and improving systems and interconnectedness, I think, in each of them. But that is where it stands at this point, and how each of the states received, again, within this framework of requirements, but focusing on the specific needs of their states.
Great, yeah, thank you. And so this was one of the provisions of the bill that spent money, but as we heard at the beginning, overall, the bill saved money and spent less money than would have otherwise been spent. And one of the ways it did that was by adding work requirements as part of Medicaid. Cheryl, can you tell us a little bit about what the work requirements are and why they save money?
Sure, I will go into it a little bit and then hand it to Verlon. As you can see, we work closely together. We'll both dive into this. So, worker community engagement requirements are such that individuals who are not children, not the disabled, not the aged, are engaging in community either through volunteering, school. There are other ways, but with the concept of full community engagement to the extent possible for individuals receiving Medicaid. And one of the reasons it is, I think, a bit daunting for thinking about implementation of it is the need for there to be a way to let the Medicaid agency know that those requirements have been met. And again, we talked about work requirements, but it could also be volunteering, community engagement, and other ways. And so as we move forward, I think there will potentially be a little bit of bumpiness in the beginning as states work with their stakeholders, which include large volunteer organizations. Their managed care entities will be supporting this, the Medicaid managed care entities, their educational institutions across the state to be able to figure out what is the most efficient and effective way to collect the information, which is letting the Medicaid agency know that individuals have met the requirements. And the requirements, it's a bit of a challenge given that it's a new requirement for almost every state. A couple of states had started in this direction earlier, but I think that is one reason initially in the beginning, there's a feeling that some of the people may not seamlessly make it through this process. Either they won't be aware of the requirement, they're aware of the requirement, but they're not able to report appropriately. The reporting, maybe there's a glitch in the system, the reporting isn't accepted. And I think it's just something for providers and health systems, hospitals to be aware of, that people may be coming to receive care, believe that they are covered by Medicaid. And again, there may have been a reporting glitch. There may have been some other issue, which when the person shows up for care, they're not under the care that they thought that they had. So there may be some need for assistance. I think for health systems too, it's important to think not only from the perspective of people who are coming to our system to receive care, but also as an employer and as entities which have a lot of volunteers. It is likely a need, there may be a need to support those individuals who are receiving their status for having fulfilled the requirements through either working in the entity or volunteering there, a way to get that information back to the Medicaid agency or to support the individual in getting the information back to the Medicaid agency that will help them continue to receive coverage under Medicaid as well. So a couple of different perspectives and lenses to look at this through, but there is sort of that concern that there may be people who fall through the cracks, just given the implementation of the requirement. And so with that, I'm going to turn it to Verlon for a different perspective or to fill out what I missed.
Really, Cheryl, I don't know what else I could say than what you said. Let's just work and community requirements are now part of the policy landscape, right? And states, are focused on implementation. You hear real health, you hear work requirements. This is what states are really focused on, right? And so I think that the real question for states isn't philosophical, it's more operational at this point, as Cheryl's pointed out. How do you implement these requirements in a way that complies with federal law without increasing unnecessary coverage laws or administrative burden, right? Those are the key questions. And we've been down this road before, and so there's a lot of learning behind that. And I think what we've learned from past experiences is that the design details matter. How exemptions are held, right? How are we handling that? How verification of structure is important. How often people have to report, and then whether systems can automate those processes is really important. So that means that states that rely heavily on manual processes or outdated eligibility systems could face a much higher risk of churn, and churn means people coming on and off the program, right? And not because people are ineligible, but it could be because systems really can't keep up. And so I talked about modernization a bit earlier. And so the important thing here is that modernization, data integration, and clear communication with beneficiaries is going to be so important at this moment. It's really vital, right? And so what we're seeing then is really states approaching the work community engagement requirements differently based on where they are with their systems and their populations and their policy, their state policies, right? So some are building them into some of their existing eligibility and workforce systems to really minimize disruption. Others might be moving more cautiously, right? Phasing implementation and watching kind of early impacts closely. But across the board, really states are really trying to balance compliance with continuity of coverage. And that balance really depends heavily on administrative capacity for them too as well. So again, a very important piece of what's happening with the Medicaid program, really trying to move it into to a positive direction. And so states are really grappling with that idea of like, what is it they need to do to make sure that it's done successfully for sure. So it's definitely something to watch out.
Thanks. So reading between the lines, what I'm gathering is the law passed in July.
Yeah.
States are now have to figure out how to implement the work requirements. So there's likely to be a variety of approaches amongst all the different states. And then how long is this going to take? So when, if you're a provider, when should you expect to see the impact of, oh, this person didn't meet the work requirement, therefore they don't have Medicaid?
Yeah, so let me put that a different way, right? So this is really an opportunity where we're really seeing the program evolve, right? And so this isn't something that states can just do on their own. They're going to really have to reach out to their vendors, their current vendors, future vendors, right? That can really help them with these processes, right? It is about like engaging with the providers early, right? To make sure they know what the changes could be, that they're able to handle it. Can they, how can they work with states on this, right? Their states are already asking those tough questions of their vendors, their plans, and their partners, right? We have this eligibility system, we have this solution we need to have. What can you do to help us? Can you help support the coordination of that? Can you help with administrative burden? So I think it's really about partnership here. and really about leaning into all the individuals who are able to make this a successful program. But I'll turn over to Cheryl, though. I know you'll have some things to say about the providers for sure.
Yeah, I think in the coming year, so 2026 is really a partnering, building, putting the pieces together, defining what counts basically as community engagement within each state, how that will be reported, how that will be integrated, and what the impacts will be. States have the ability, it may depend a little bit on which state you live in, when and how quickly some of this rolls out. It could begin. I could see it beginning towards the end, middle to end of 2026 for some states. And then really, I think 2027 is likely where we'll see the impact on the individuals coming in to providers. Hopefully, the partnership has been really strong. The planning has been great. And we see very little impact. But I think we would start really seeing it in 2027. So that's why 2026 is a great year for partnering and making sure that there's a plan, there's a contingency plan, and there's really a way to work together to keep people covered, to make sure people have access to care.
Yeah, and I just want to just say again what you just said because it's worth repeating is federal state partnerships are really becoming more collaborative and also more demanding, right? And so you're needing clear data, strong evaluation, measurable outcomes for sure, but providers here really play a critical role for engaging early, participating where appropriate, and really helping to pair that real world experience with credible data because this is how policy improves, right? When operational reality informs decision making is where we're really trying to get to. So again, as Cheryl said, I cannot stress the more of the importance of partnering in all of these efforts for sure.
Great, thank you both. And earlier we talked about the it's a federal matching program, and so in order to draw down the federal dollars that a state is entitled to, it has to spend money. And one of the ways states get that money is through provider taxes. And so in this law, there was some concern, I believe, that some states were abusing the provider taxes and essentially recycling federal dollars to draw down more federal dollars. So the bill included a provision or provisions to stop that. I guess whoever wants to go first, can one of you please tell us about what did the bill do? What problem does it solve? And why should we care about it?
Okay, so I'm just going to start off and set Cheryl up, okay? Because as she said, we work so well together. This is where she shines for sure. Yeah, but you're right. You're right, Jim. On the financing side, changes affecting provider taxes and state-directed payments have really been considered very carefully in this. And I just want to stress that these tools have long been central to sustaining provider networks, especially safety net and rural hospitals, and small adjustments really could have outsized effects for sure. But again, let me turn it over to Cheryl. She can walk you through how states may be thinking about these financing levers, what the trade-offs may look like and what providers should be paying attention to as the decisions unfold for sure. So Cheryl, educate us.
I'm laughing because, as Verlon knows, I love Medicaid financing. When I found it, it was the love of my life. Don't tell my husband, don't tell my kids, don't tell the dog. Medicaid financing, I love it. So, and I think it's important to step back a little bit that the federal state partnership sets up some inherent tensions with, what is the right amount to match? We call it sometimes the Goldilocks, like don't take too much federal money, but states also don't want to take too little. We're going for the just right when it comes to that matching. And some of the provisions, there are multiple ways to fund the state match portion. One of the most popular is general funds. But then there's also provider taxes, or even my favorite, bona fide provider donations, which is always, I love those that cracks me up for some reason. And in addition to other ways that states use to fund their programs, there are other ways, including intergovernmental transfers or IGTs and certified public expenditures, in which entities which receive tax funding or other funding can at the lower than state level can provide that money to the state as state match, basically use that as state match, or from a sister agency. Sometimes you see that from the Department of Education or something like that for school-based clinics. So there are different funding mechanisms that states can use. And if you put a couple of those together, states have found ways under provider taxes to have something that appears to meet the requirements, or technically meets the requirements of a provider tax being uniform, generally redistributive, and not holding harmless the tax-paying entity. So those are the requirements when it comes to provider taxes. States have figured out clever ways to maximize federal revenue using provider taxes, for example, in combination with those intergovernmental transfers. And that has led to the amount that the state is drawing down, the federal match percentage, to increase beyond that within the statute, essentially. So there are ways to recycle the funding through provider taxes and use of some of these other mechanisms. That has been a part, I would say, of the Medicaid partnership sort of from the beginning. The identification of ways to maximize revenue and ways to sort of get back to the Goldilocks, the just right amount. Within OB3, we saw a couple of those come into being, some of those corrections within statute to hit the Goldilocks amount. And within those, we saw a provision prohibiting states from raising additional revenue through new taxes or increases in provider taxes beyond what had been in place. On July 4th, we also see some requirements regarding that tax uniformity, further limiting in statute what's considered generally redistributive. And then we also saw requirements that changes to the threshold for hold harmless, one of the other prongs of broad-based healthcare related taxes, including the permissible size of provider taxes, and that decreasing from 6%, which is sort of the safe harbor at this point, down to 3.5% in fiscal year 2032 and thereafter. So really, it's a limiting of the current use of some of those provider taxes, and that and then that's in expansion states for that down to the 3.2%. But overall, it's a limiting of focus and greater oversight generally of provider taxes. At the same time, CMS is making some changes. We actually anticipate a rule coming out shortly that will implement additional provisions looking at hold harmless, as well as implementing some of these provisions to focus on that balance of keeping the right amount of the federal funding flowing into that formula across the partnership.
Thank you, Cheryl. So we went over the three big things: the Rural Health Transformation Program, the work requirements, and provider taxes. Are there any other changes at the federal level in Medicaid policy that we should be paying attention to? Verlon, do you want to go first?
Yeah, I think so. So I had an opportunity to really be more surrounded around some of the key things that are happening at CMS related to this CMS health tech ecosystem. And I think while states are working through a lot of these changes that we've heard about, we're also seeing, I think, an important signal come from CMS leadership under Dr. Oz around the role of technology in the next phase of the health system transformation. So I don't know if you all have seen, there's been some recent announcements emphasizing technology-enabled care, interoperability, and data liquidity. But what's different is that Medicaid is no longer treated as an afterthought, which for those of us who have been Medicaid fans have found this to be such an exciting time for sure. And we're actually seeing this reflected, I think, in some of the newer CMI models that they have, including the one that's called Access, that emphasizes, technology supported access and coordination in ways states can align with Medicaid delivery systems. So even when Medicare is the entry point too, there's this clear recognition that innovation can't succeed at scale if it doesn't work for dual eligibles that Cheryl had talked about, those who are eligible for Medicare and Medicaid, and are usually our most frail population, but also for people who move across programs. So there's a clear signal that that's really important. And so, I think that this is something that we should all be learning more about and really seeing how we can engage in that from all aspects, whether we're providers, vendors, or others that may be interested in really helping us move the needle further. So that's one of the things I think is really important and really kind of cool, honestly, to learn more about.
Thanks, Verlon. Cheryl, any changes you're following?
Yeah, a couple. I'm going to start with the state directed payments and limitations focused on that. Those are essentially supplemental payments that states are able to make to providers through managed care entities. And CMS has been focused, as well as OB3 had focused on some limitations related to those and keeping them at a Medicare level rather than commercial level and some other things like that. So I think we're going to see more of a focus there. Those are the managed care equivalent to the fee-for-service upper payment limit or other supplemental payments. So more to come in that area, interrelated with the tax issues as well. A lot of excitement in financing in Medicaid coming up. I'm trying to make Verlon laugh with that, but I think a lot of people will be focused on that coming forward. I do want to go back to the point that Verlon was mentioning. I think we're going to see a lot, both with the innovations through integrating IT for care delivery, so tech-enabled care delivery, and also just efficiencies and improvements within IT systems to support Medicaid through the challenges ahead, but also to integrate through the opportunities, including the rural health transformation. I think there's just going to be a lot happening in that realm, which is really exciting for all of us. And we'll, I think, be looking at some interesting ways to support that overall from different parts of the healthcare system. How do we do that better by pulling in all of the parts of the system, all of the payers to work together towards that? And I think rural health transformation could be a real leader in that. I also have seen, I want to highlight for the new ACO program, the LEAD program on the Medicare side, which is the extension of the it's next gen for REACH ACO. CMS has called out that they will be working with providers and states to identify a couple of states within that will focus on integration across Medicare and Medicaid. And LEAD is anticipated to have sort of stronger upfront financing to focus on rural providers, medically underserved, people working with more complex populations. And I'm hoping it's a signal for future, again, partnership across providers, Medicaid, and CMS, the Medicaid agencies and CMS, in promoting care for those populations that really need it the most.
Thanks, Cheryl. So at the beginning, we mentioned that Medicaid covers a lot of births, so maternal and child health care is important. They cover a lot of nursing home costs, so long-term care is important. And then, of course, hospitals and health systems also see a large percentage of payments from Medicaid. So how does all this, if I'm a provider, how does all these things we've talked about, what should I be doing now, and how is this going to impact me?
Do you want to start, Verlon?
I'm gonna let you take it. You work really closely with providers. There you go.
I think for providers, that focus on the intersectionality across healthcare with the opportunities to innovate. But going back to what Verlon mentioned earlier as a critical component, which is the voice of the providers and how these policies are truly impacting people on a day-to-day basis on the ground? Is it enhancing your ability to provide care? Are the policies and payment incentives, hindering that in any way? Are there opportunities for policies to change to better help you provide care? My ideal of our healthcare system truly is the person is in the middle and it's sort of surrounded by uh, regulations and policies and payment, which all incentivize driving towards what the person needs to have the best health outcome. And I think the critical aspect that only providers, health systems, and others who work caregivers who work one-on-one with those in need of care and their advocates, they provide that back. That is the information that makes policy work. So I'm a little obsessed with the intersection of policy and operations. How do we make this actually work? And then how do we take the things that aren't working back to change the policy so that we can just get to what everyone wants, which is great care provided efficiently and effectively that helps people have better lives and better outcomes and thrive. So I'd say just be a part of the conversation and keep the policy, I guess, accountable and the policymakers accountable and informed so that we can have that type of healthcare system.
Yeah, I agree. I mean, nothing really to add except, just one statement, which is providers are often the first to see unintended consequences for sure. And I think about when there were issues with prior authorization, when there were reporting processes or even the eligibility churn that you saw, because all these systems maybe created some type of barriers that we got feedback from providers, right? And so really being more specific about what you're seeing, and really more social solution oriented, I think would be really helpful for providers. So, we need the providers to really make the system work best for sure.
Great. So what I'm hearing is the bill passed in July, but still a lot of work lies ahead for states to figure out how to implement provisions. And CMS is also making some of its own rules. So providers that are paying attention have the opportunity to comment and engage to shape without having to rechange the law to make the law work better for them than it would if they didn't engage on it. So with that brings us close to the end of the Northern Virginia Health Policy Forum. But before we wrap up, I'd like to ask each of you, Verlon, I'll ask you first. What is the one thing that you would like our audience to remember from our discussion today?
I only have one thing, Jim, just one. Okay.
I can only remember one thing.
Okay. I think one thing I'd say, there are no foregone conclusions. How's that? We've been here before in different ways. We've seen supplemental payments, we've seen UPL limits, we've seen managed care and transitions for sure. And each time this community didn't just adapt it, they innovated, right? Even now, progress may come in phases, as we've talked about for sure, but the trajectory is really going to be clear. Medicaid endures because it evolves. It's guided by data, it's grounded in reality, and it's strengthened by partnership. And so if we keep those things in mind here, we will see a stronger and a better Medicaid program for sure. So there you go. That's my one thing you allowed me to.
Thank you, Verlon. And Cheryl, what's your one thing that you'd like our audience to remember today?
Verlon, would you like my one thing too? We could arrange that.
Yeah, right.
I will highlight. I think it's, things are dynamic, they're evolving, as Verlon was saying, and making sure that your voice is heard. You're, there building this, continuing the partnerships, building the solutions, and keeping an eye on the ball when it comes to Medicaid changes, but also understanding that there are all of the Medicare changes, there are things happening within Marketplace, and pulling that all together. And keeping policymakers informed of what's happening. The good, they like to hear what's happening. We know what is happening that is good, so they can do more of that. But also what isn't working, and bringing data to show potentially not only what isn't working, but how can it work? What is the solution that on the ground will actually work based on experience or based on some testing or partnership development among providers? I think helping light the path forward is, a great place to be.
Great. Thank you, Cheryl. This brings us to the end of this month's Northern Virginia Health Policy Forum. Thank you, Verlon and Cheryl, for sharing your knowledge and insights on the recent updates to the Medicaid program. Thank you also to the Applied Policy team who worked behind the scenes to put this together, especially Annie. And before I close, we just sent a message in the chat with links to subscribe to our monthly newsletter and view our Northern Virginia Health Policy Forum website for more in-depth insights into current and perhaps future health policy. Thank you for being here and enjoy the rest of your day.